one of the things that I had the hardest time wrapping my head around was that statistics will never prove anything. And what I mean by that is you can use statistics to define how closely associated two variables are. And so a classic example in health and medicine is cigarettes and lung cancer. So the statistics tells us that there's this positive correlation between the number of packs of cigarettes you smoke per day, for X number of years, and the incidence of lung cancer. And so we have this positive correlation, the statistics agrees with it, and people look at this data and intuitively they say, this proves that smoking causes lung cancer. And you're wrong. All it says is that there's a correlation between smoking cigarettes and lung cancer. And so it's not saying that it's causative though, because there can be other things at play here that are causing this thing to happen. And we don't live in a universe where it's possible to control every single confounding variable and only change this one thing. Like, we're not able to run a randomized controlled trial ethically where we have one group of patients who smoke 10 packs of cigarettes every day, and then we have another group of patients who never smoke at all, and everything else about their lives is identical, and they're all genetically identical, and we can compare these things. Like, it's just not possible to do these things. And so what we're left with is just a bunch of statistics that tells us that there's a positive correlation between doing these two things. And it kind of sucks, because I think a huge part of human nature is wanting to say, like, this is why something happens. Like, when you see someone with lung cancer, you want to ask, why do they have lung cancer? And you want to hear someone say, it's because they smoked all those cigarettes. But there's people who get lung cancer who never smoked at all. And so it's a very difficult thing to wrap my head around. And one thing that really tripped me up a lot was this notion that, if all we're able to do is draw correlations, then, if the purpose of science is to discover the truth of whatever given field that we're exploring, then how do you ever prove anything? Like, can you prove anything scientifically, or are you really just adding credence to some prior notion, or disproving, taking away credence from another notion? And that's really all you're doing. So people also are usually more interested in studies that are finding new things, not things that didn't find anything. So it's like, you may have conducted some huge experiment to say, like, we wanted to see if this was a correlation between this variable and this variable, and then all you find at the end of the day is that there's no correlation, even though that's statistically relevant, that null hypothesis is true. You can't actually do anything with it because people don't really care. Like, we don't care most of the time. And so the reason I'm bringing this up is that as a medical student, it's still kind of been in the back of my mind, and I've thought about it when, you think about your work and you think about your patients and the work that you put into developing a treatment plan for a diagnosis you have. And so, to give an example of something I was learning today that I think really kind of hit home this notion of, the blend between science and statistics and healthcare, for me, had to do with this disease called leg length discrepancy. And so LLD is this thing where basically you have two legs and they're not necessarily identical. And so in some patients, they have legs that are a lot longer than the other, and we call the shorter one the short leg. And so how much shorter the short leg is makes a big difference, because if you think about human, like, if one of your legs is that much shorter, it's not just gonna be like, oh, okay, well, you just bend your knee a little bit and you just live like that. It's like, no, there's some pretty big modifications that your body's going to do in order to compensate for the fact that your leg is shorter. So it's going to go up through your knees. It's going to start at your feet. So your feet on your shorter side will actually begin to supinate. So they will kind of do this to kind of raise up that tibia a little bit. And then on the longer leg, your leg will actually pronate slightly to kind of pull down that tibia. So just some correction there. And then up in your hips, you're also going to have this thing where, on that shorter leg, so this was a shorter leg, you're going to have pelvic tilt. And so on your pelvis, you've got these iliac crests that you can palpate. And so basically what you're going to see is that your pelvis also is dipping down because you have that short leg. And because you've got that short leg, also what's attached to your pelvis, it's attached to that sacrum. And then on that sacrum, you've got the S1 through S5 vertebra, and then you've got these lumbar vertebra as well. And so as that sacrum bends, you're going to have the spine going up at an angle no longer perpendicular to the ground. And because your spine is now doing this, over time, because of that short leg, the spine's going to begin to develop a C like that. And then over even more time, as these things become even more chronic, that C shape can become an S, and you'll get some secondary curvature here. So your body over time will accommodate all these things, and the effect of it can be things like, that would be scoliosis in your spine, is going to be leading to potential nerve compression because you've got those spinal nerves that run out of those vertebral foramen. And so in those areas, people will say, I've got low back pain. And, people look at it and think this person's a candidate for surgery, and they're going to want to, start ramping up, getting prepped and all this stuff. And in reality, the treatments can be very, very simple if you know where to look. If you look at a patient who's presenting with low back pain in these specific instances where they've got short leg or leg length discrepancies, you can go in and you can, on their shorter leg, put in a heel lift that will basically lift up or increase the effective height of that short leg so that it's now on the same level as the longer leg. And so once you do this, the body that was taking on all these different contortions just to compensate for the fact that you've got a shorter leg is now able to return back to this more neutral position and hopefully restore and alleviate back pain. And so, this is the thing with science, is like, we've got this, idea, we've got this hypothesis as to how something works, but can we really say it's causative? Like, can we say that the reason why someone stops feeling low back pain is that you gave them a heel lift of the correct length when you identified them as having this leg length discrepancy? And this is the thing that kind of is, for me, a bit of a bummer about science, is that we can't really say yes. We can't say yes. But what you can do as a healthcare professional is that you can ask your patient, how do you feel? Like, you came to me because you had low back pain, and we gave you this heel raise, and these x-rays, everything I can see with my eyes is telling me that because you no longer have this pelvis that's tilted, you've got a level pelvis and you've got a spine that no longer has this scoliosis, then we wouldn't expect to see that kind of mechanical stress being placed on those spinal nerves. Hopefully this would alleviate your back pain, your low back pain. You can just ask the patient, how do you feel? Like, did I do my job? Did I accomplish my mission in alleviating pain? And so that's the thing that you get out of healthcare, is that we're not necessarily doing the science. We're just seeing this thing, this dysfunction, for instance, and we're just correcting for it. And the hope is that it helps our patients live better qualities of life. And that's the mission at the end of the day. It's not to figure out, well, why did their pain go away? We've got an idea, but it's just an idea. It's not the cause. Could be the cause, but we don't know. But all we do know is what the patient tells us and how they're feeling. And so that's the whole purpose behind healthcare and treatments, is that, like, we very well might not have even, that heel lift might not have even fixed the problem. I will say that there are cases where you have patients who have the heel lift and then they take it away because their pain goes away, and then when they take it away their pain returns, and then they go back to the doctor and they say, "Doc, why does my low back hurt again? Like it was hurting a few months ago." And the doc says, "You got to keep wearing that heel lift thing because your spine will just keep coming out of alignment every time you don't do this." And so like that kind of reinforces this notion that the heel lift does solve this back pain because of that leg length discrepancy. But again, we're not definitively proving anything. It's really just about the patients and their health outcomes and seeing if the patients now feel less pain. And so that is the thing that I've been kind of really thinking about in terms of being a medical student and healthcare and what our real purpose is. And it's not necessarily science. Like, we're not here to ask why. That's the mission of scientists, is to, in my opinion, to ask why and to propose hypotheses and then test those hypotheses and test the hypotheses of others and continue to seek for truth in this universe. And healthcare is not necessarily about that. It's about helping your patients live the lives that they want to live. And so I think I'm going to wrap things up with that. I hope this is interesting stuff. Thank you all for watching. I hope everyone out there is doing well, and I'll talk to you guys next time.